Okay, so what are anxiety disorders? Well, generally, they're disorders that include a lot of anxiety, okay, but not just random or understandable anxiety. I'm not talking like, oh, the night before a date, you are nervous, or the day before a test, you're nervous. This is distressing nervousness and almost constant or persistent apprehension. And a lot of times we're going to attempt to self-soothe that anxiety, which can lead to maladaptive behaviors or coping mechanisms, whether it's coping through substances or it's coping through behaviors, like what we're going to see with OCD. Obsessions are recurrent thoughts or intrusive thoughts, whereas the compulsions are persistent behaviors or rituals that emerge in order to placate the intrusive thoughts. Okay, so we could have a number of maladaptive coping mechanisms that emerge with anxiety, like someone with social anxiety, okay, may get along better with people when they're at a bar or drinking. And so they may rely too heavily on that crutch in order to get over their social anxiety. And oftentimes, even though we can't ascribe a disorder directly to one singular cause, there is a high correlation between victims of abuse, especially when they're children, and higher levels of anxiety disorders. Now, some of the characteristics of anxiety include anxiety. Okay, you're worried or you're afraid. You don't like uncertainty. That uncertainty makes you nervous most of the time. You're constantly worrying about what could happen or what is happening. Okay, that leads to higher stress and higher stimulation of your sympathetic nervous system. You can be oversensitive, and this doesn't just mean oversensitive to your own emotions. It doesn't mean like, oh, at a drop of a pin, they'll start crying or think that, you know, people hate them. This also includes being oversensitive to other people's emotions. So tying back to this etiology of, oh, people who have suffered abuse have higher rates of anxiety disorders. Well, one of the coping mechanisms or survival mechanisms that people who've been abused develop is they learn how to very closely and accurately monitor their abusers, especially their emotional states, okay, so that they can try to foretell of any acts of violence or abuse that may be brewing, okay? And so they could be oversensitive to facial cues and to emotional expressions because they have survived by reading their abusers' emotional expressions in order to try to protect themselves. Okay, so they may even give themselves anxiety over how other people perceive them or react to them unnecessarily because they can't read other people's cues properly. They see it only as a life or death situation that has been overstimulated over time. Also, difficulty concentrating. That goes back to the Yerkes-Dodson theory of arousal. Okay, remember, if you're completing something that is complex, you need to focus. You can't be distracted, versus if you're doing something not complex, then you can be distracted. And so anxiety itself can be one of those distracting features, like in testing anxiety. You're trying to take a test and you run out of time because you just spent the whole time sweating and thinking, okay, I'm going to fail this test. I'm going to fail this test. Also, this can interfere with sleep. It can cause insomnia. Now, insomnia isn't, oh, I'm trying to go to bed and I can't go to bed one night. It's persistent lack of sleep. Okay, it's persistent inability to get or to stay asleep. Although after spring daylight savings, I am very easily going to be able to pass out tonight. This can also lead to exhaustion. Okay, remember when we talked about the general anxiety disorder when it came to the 3 phases? The last phase after, you know, alarm and response was exhaustion, because your sympathetic nervous system, your fight or flight system, is flooding your body with adrenaline and cortisol. And that is expending a lot of energy. It's tensing a lot of your muscles. So eventually your body is going to give out from the anxiety and from the stress. Are we good so far? All right. So generalized anxiety disorder is when a person is in a persistent state of fight or flight. Okay, so they're tense, fearful, and they are ready to go at the drop of a hat. Okay, so some symptoms of that generalized anxiety could be random sweating, their heart racing, near syncope, which is almost passing out, dizziness, shaking, and of course, fear. Now, this isn't necessarily triggered by a specific event. So like if someone has PTSD and they hear a song on the radio that reminds them of the traumatic event, then they might be triggered. Okay, that makes sense. There's a causal relationship of, oh, hearing that music, that particular song reminds me of that event. And so I'm going through an intrusive thought process from the trauma. With generalized anxiety disorder, there isn't really a cause and effect. It's not a specific event, it's just there. Okay, and this has to be persistent throughout months of time. So it can't just be, I'm really anxious for a week and I'm on edge. It has to be for 4 months or more. And that's one of the classifications that's designated in the DSM for helping people make these diagnoses. Like, are they just stressed? Is it a stress disorder or is it an anxiety disorder? Does that make sense so far? Now, a panic disorder is the more extreme form. It's more intense, okay? So a panic disorder is often confused with heart attacks because it has similar symptoms. Your chest will hurt, your arms might hurt, you might tingle, you might pass out. People who go through panic attacks feel like they are literally, not metaphorically, but they are literally going to die. And oftentimes will go to the ER thinking that they need a CT scan of their heart because they think that they're having a heart attack. In reality, it is a panic attack. Now, this isn't always triggered by a real threat, okay? They can be very unpredictable. Whereas with PTSD, you can tie it to a causation relationship or a causal relationship regarding triggers. Panic disorders can be completely unpredictable with intense terror, and then you just have to ride it out, okay? And so the use of those grounding techniques, like the breathing on a count of 4, 4, and 8, holding an ice cube, okay, helps because of the texture of the ice cube, but also if you hold it long enough, your hand will start hurting, okay? And it will ground you in the reality of what's going on. Or grounding using your senses, 5 things you see, 4 things you hear, 3 things you smell, and so on, okay? Now, panic disorders and anxiety disorders occur in a higher rate in women as opposed to men. Particularly the panic disorder tends to affect women twice as much as men, or they're more likely to suffer from panic disorders. Now, there's a lot of different arguments about what causes this. Could be different. It could be biological with difference in hormones or neurotransmitters. It could be different coping skills that have emerged, or it could be a sociocultural model. From my experience as a woman, there are a lot of things that women do or don't do in response to perceived or possible threats, like walking to your car alone. You put your keys in between your fingers, or they sell little gadgets that you can hold on, or panic alarm apps for your phone. Going outside for a walk at night with headphones in, can't do that. Okay, texting your friends where you're going to be and who you're with and their contact information if you go on a date. Okay, all of these steps that women take in response to threats to their person, whether it's something that happens to them or has happened to them in the past, or it's more the fear that it will happen in the future. So trying to prevent that from going on. Are we good so far? All right. Phobias fall under the category of anxiety disorders. Now, a phobia is different from a fear. There are some things we're naturally afraid of and it's rational. Spiders, okay? You don't want to hold them. They're hideous. They have hair and fangs, okay? You should be afraid to touch a spider. But should you be so afraid that you have an irrational fear of spiders that you burn your house down if you see one? No, something else, like maybe, depends on the size of the spider. Okay, so irrational versus rational. A fear of heights. Okay, if y'all go up on a tall building and you peer over the side, your hands might start getting sweaty, mom spaghetti. Okay, but that's a evolutionary, thank you, Nathan. That's an evolutionary response to say, okay, back up, that's too high, you will die to death. But if you're so afraid of heights that you refuse to go above a second floor, or a second story, that's a phobia, okay? Enclosed spaces, claustrophobia, all of that. Those are all very common, but these phobias are persistent. It's not just a temporary thing like, oh, I saw the movie It by myself, and so now I'm afraid of red balloons and sewers. Okay, this is something that's going to be persistent over a period of time. It's going to be irrational, and it's going to be maladaptive. Okay, social phobias, that involves fear of being embarrassed in public. So like public speaking, this can tie into social anxiety. And one of the causal or the etiology of social anxiety relates to parenting. There's some ties to that, whether the parents are overprotective, trying to shield their child from like certain music or shows or, you know, things that they don't want their child getting into, or if they're rejecting parents. Okay, because remember, the parents are the first humans that you come into contact with. Okay, they're supposed to define your love map and your interaction with other humans. So if they're rejecting to you as their child, then you're probably going to have issues with social anxiety in the future with people outside of your family. Okay, agoraphobia is, you probably have heard of it before. It's a fear of public spaces, and in its extreme form, it can lead to a fear of leaving your house. Okay, so being stuck in your house and afraid of leaving it for a number of reasons. It could be in result of a trauma. It could be overwatching the news and you know, seeing everything that's going out in the world, and you're like, the world's going to crap, I'm going to stay inside. It could be related to germophobia, like you don't want to go outside because that's where the germs are, and you clean and bleach your house obsessively. Okay, but typically agoraphobia means that they don't want to be in public spaces or around a large number of people. Alloreophobia is the fear of cats, which I definitely do not have, and I'm very grateful for. I'd have to get some therapy for that, exposure therapy. Okay. Now, the difference between a phobia and a fear is that fears are normal. Fears are common. Okay, they're a common survival response, else we wouldn't have an amygdala. But phobias are extreme. So as you can see here, there's much higher rates of reported fears rather than reported phobias. Okay, because a fear is natural, it's adaptive evolutionarily. A phobia is extreme. Does that make sense so far? All right, so some specific phobias. Trichtophobia. What do you think that's a fear of? Don't say Taylor Swift. You're watching the Grammys and you're like, folklore.
13.
Yeah, a fear of the number 13, which is Taylor Swift's lucky number. Okay, but in American culture, 13 is often associated with bad luck, okay, or danger. And that those numbers can change according to culture. Another number that the American sociocultural model tries to shy away from is 666. Okay, so if there's like 666 together, okay, someone's going to say something about it, and they're going to be talking about the devil. Then Friday the 13th. Were you born on a Friday the 13th, Nathan? You don't know? You could look it up. You can look up the year and he'll tell you. I was born on a Thursday. So yay, weekend. So yeah, Friday the 13th, it's a part of horror shows. In China, okay, what do you think their unlucky number is? Does anyone know? Good, the number 4. Okay, because the word for 4 in Chinese sounds a lot like the word for death in Chinese. Okay, and so that is a unlucky number. In America, 4, it's just a number, but 13 or 666, we get it. I think even some elevators skip the 13th floor, like they just don't have 13th floors. Like it just goes from 12 to 14, and they're like, because superstition. All right, what about this phobia? Trichtophobia. Hair, exactly right. This is different from trichomania. Okay, trichomania is when someone obsessively pulls out their own hair. So they'll over tweeze their eyebrows or their facial hair, or they'll start ripping their hair out of their scalp as an anxiety disorder. Okay, but this is the fear of hair. Although I'm not really afraid of their hair, I'm just afraid of them. Or maybe it's that movie, The Ring. Do y'all remember The Ring with that little girl in the well and she has the long black hair and it comes out of the TV? I may have a little trichtophobia. Okay, obsessive compulsive disorder. I know y'all have heard of this disorder before, but it's often misconstrued in terms of what it actually is. Like someone might say, oh, I have to put all of my color palettes in order, I'm so OCD. Or, oh, I have to make sure that I do the dishes right after eating, I'm so OCD. That's not really what OCD means, okay? It's a disorder, which means it's maladaptive to behavior. So obsessions are recurrent thoughts, often intrusive, okay? And a lot of these obsessions relate around fear of what could happen, fear of something bad happening. And they're intrusive, so they're going to happen over and over and over again. You can't just say, I'm not going to think about that. It's going to come into your brain and say, intrusive thought, intrusive thought, intrusive thought, and you can't get rid of it. So in response to that obsession, we try to cope by developing a ritual, a compulsion. Compulsions are recurrent behaviors, okay, that soothe the fear. All right, if I do this, then nothing bad will happen. And then that can appease the thought until it comes back later and you have to repeat the ritual. Okay, so for instance, if you're germophobic, you're afraid of getting sick, okay, that intrusive fear is going to lead to you doing certain behaviors like overwashing your hands or boiling the water really hot to wash your hands or scrubbing too hard and exfoliating too hard when you shower, okay? But you're going to use that as a way to stop the intrusive thought of you're going to get sick. You're going to say, oh, well, I'm going to take a bath in bleach. Some people have done that, okay, in order to prevent from getting sick. Or you may think, if I don't flick this light switch 4 times exactly, then something bad will happen. Okay, so they'll flick it 4 times, and then when nothing bad happens, that reinforces their behavior because they're like, oh, it worked. That's operant conditioning. And they're not going to test the theory of, well, what if I flick it 5 times? Because they don't want to test the theory of what if something bad happens. And so it's naturally reinforcing. Every time they do the ritual, the obsession calms down and then nothing bad happens. And so they continue in that cycle of obsession and then compulsion. Does that make sense so far? So what does this look like biologically? Well, people with OCD often have lower levels of serotonin and dopamine. Remember that serotonin helps regulate positive moods and dopamine is the pleasure chemical. Okay, so they're not getting their nucleus accumbens stimulated. They're starved for those chemicals. So maybe their amygdala is getting overstimulated, which leads to them overestimating threats. Okay, so like if you're afraid of the number 13, you are overestimating the power of a number. If you have germophobia, you're overestimating the likelihood of you getting sick and dying from a germ. Okay, so they overestimate those threats, and so they're constantly in a period of anxiety. They also have intrusive thoughts that they can't get rid of, hence the need for the rituals. And they also have an intolerance of uncertainty because that means a lack of control in their environment. Something bad could happen. They try to control their environment through these repetitive rituals. Okay, so if you see someone who suffers from OCD and everything's in a certain place and it looks all nice and tidy, okay, that's because they don't want uncertainty. They want to know where everything is so they can control their environment. Just being neat doesn't necessarily mean that you have OCD. Okay. Now, one of the treatments for OCD is exposure therapy. Prevent them from doing the ritual, show them that nothing bad happened, but that's really, really hard to get through people's heads. It's kind of like the same thing if someone's watching a sports show, like their favorite team, I don't know, sports ball, and they wear the same pair of socks for every game, and they think that as long as they wear those socks, their team is going to win. Is there any correlation between you wearing your funky socks and someone winning the Super Bowl? No. But then let's say their mama washes those socks because thank you. Then they freak out and they're like, well, now my team is going to lose because you washed my socks. It's that same kind of mentality like with superstition. But it's comforting Hence, it provides a feedback loop of operant conditioning. Are we good so far? All right. PTSD. That stands for post-traumatic stress disorder. This is extreme anxiety caused by extreme situations. Now, there's two types of PTSD. There's the type that most people know of, where someone's gone through a life or death event, a trauma, an extreme trauma like warfare or assault or abuse. And then there's complex PTSD, where it wasn't a singular life or death event, but a series of traumatic events that may not have reached the threshold of life or death, but were still traumatic, that eventually build up to PTSD. Okay, so some people who've survived childhood abuse have complex PTSD because it may have been more mental or emotional abuse rather than physical or sexual, but it's still PTSD nonetheless. Now, a lot of people, when they think PTSD, they immediately think, oh, military. Okay, and that's true. Like, it could be a event where an IED exploded or they lost members of their unit, but that's not the only way that someone could get PTSD, or as it was called in World War I, shell shock. Okay, other experiences that could be life or death or just traumatic can result in this disorder. Okay, so symptoms of PTSD: difficulty going to sleep, nightmares. That comes under intrusive thoughts. When you're sleeping and you're awake, you're going to have intrusive thoughts, or flashbacks. Now, a lot of times this flashback scenario is portrayed in media as like really lifelike, and they're like in a psychotic break and they don't understand what's going around with them. That's not really the most common form of flashbacks. Oftentimes flashbacks occur in nightmares or in just intrusive memories. So like listening to a song on the radio, and that triggers them back to the attack or whatever it was that went on. Okay, they're still able to interact in their environment, know what's going on, but they may be debilitated by the emotions that are caused by that flashback, and thus have an anxiety attack as a result. Also, survivor's guilt plays a role in PTSD, and hypervigilance. Hypervigilance is when they overreact to sounds or images or movement because they perceive it as a threat. Okay, like if you walk up behind someone with PTSD and you put your hand on their shoulder without them, like without saying like, hey, it's me, they may jump. Or a loud noise may cause them to duck and cover. I know my guardian, when she returned from her tour overseas, she was so happy to just get in the shower. Okay, because they were showering using water bottles, right? So she was happy to just take a long shower and get all the sand and dust off. But then she accidentally knocked her shampoo bottle onto the floor, which, as y'all know, the shampoo bottle hitting the floor makes the loud, it will wake up the dead. So she immediately responded by dropping to the ground and taking cover. Okay, that's the kind of flashback that we're talking about. It's immediate hypervigilant reaction to something that's not a threat. Now, did she continue to think that she was still in Iraq after she, looked around? No. Okay, but her first reaction, her survival instinct was duck and cover. That doesn't mean that she went through like a psychotic break as a result of that trigger. Okay, that's media misrepresenting disorders. And according to my notes, we had left off with anxiety disorders. We talked about OCD. We talked about panic attacks. We talked about PTSD. So now let's talk about the different perspectives on what caused those anxiety disorders. Okay, so the behavioral perspective is going to deal with conditioning. There's two types of conditioning: classical and operant. One of those deals with involuntary behavior, and one deals with involuntary behavior. Okay, so causes of anxiety disorder can include fear conditioning. What type of conditioning do you think that is, classical or operant? Fear conditioning.
Is that operant conditioning?
Operant conditioning deals with voluntary behavior. So if it's fear, then that would be more closely related to involuntary behavior. So classical conditioning, kind of like what we saw with little Albert. where he was classically conditioned to fear anything that was white and furry. Okay, so fear conditioning relates to classical. Okay, a real life example of this could be a victim of abuse may develop a fear of being alone in their apartment. Okay, because they have classically conditioned the association of that traumatic event with the environment in which they experienced that traumatic event. Okay, so fear conditioning from that. Stimulus generation or generalization. Y'all may remember that little Albert indicated generalization. He wasn't just afraid of white rats. He was afraid of anything that was white and furry, and even Santa Claus. So that's generalization of that fear, as opposed to discrimination, which would be if he wasn't afraid of anything except for white rats. Okay, so stimulus generation as it relates to anxiety disorders could include you already have a fear of heights, but then you also add on an intense fear of flying, even if you've never been on an airplane, even if you've never flown. You're already afraid of heights, so it makes sense that you would combine that with a fear of flying because you fly at great heights. Reinforcement is when you engage in voluntary behaviors. Okay, so what kind of conditioning is that? Classical or operant? Good, Sam, operant. I saw you mouth it. Okay, so operant reinforcement. By avoiding the places that cause you to have fear or anxiety, that rewards you by lessening your anxiety. Same thing with OCD. You have obsessive thoughts over and over and over and over and over again. How do you appease the obsessive thoughts? You engage in compulsive behaviors, okay, in rituals. And so that allows you some relief from the obsessions, like an OCD. Also, observational learning and modeling. Okay, you could learn vicariously to be afraid of something. Like if your parents show fear around snakes or spiders or roaches or whatever, you may adopt that fear based on their fear of it. Okay, so that's the behavioral approach. In terms of the biological approach, this can include the evolutionary theory. Fear isn't necessarily a bad thing. Fear helps us survive long enough to pass on our genetic code to future generations. For instance, fear of the dark. Okay, so if you're part of a caveman tribe and it's dark outside and you're afraid of it, that's evolutionarily beneficial because it keeps y'all together in a group in your shelter, as opposed to walking around in the pitch dark, stumbling into holes or getting attacked by Mothman or something. Okay, and so the fear of the dark has some evolutionary benefit. So some fears help us to survive. So that's the biological perspective of anxiety disorder. There are genetic components to fear. There's a high correlation between identical twins who have the same genetic material and having the same phobias or the same fears with that. So it could be genetically linked. And then, of course, you have the brain part of the biological perspective. What is the brain chemistry, the physical cause of these anxiety disorders? Well, when we have fear, we see increased brain activities in the areas involving impulse control. Okay, so it's controlling those impulses. You might go into fight or flight or the freeze aspect of fear. So this shows an overactive frontal lobe, which is involved in decision making. Are we good on biological perspective? So now let's talk about the arch nemesis of the behavioral perspective. What is the antithesis of the behavioral perspective? I think Grace said it, the cognitive, okay, the cognitive perspective. This is when your thoughts are the cause of your anxiety disorder. This is when a person perceives or misinterprets a harmless situation as dangerous. Okay, so a person with OCD would see touching the doorknob as a threatening environment, a threatening situation, because they've overestimated the danger of germs. Okay, if they have germophobia. Okay, so this doesn't tie into rewarded behavior or discouraged behavior. It simply ties into what are your thoughts that are misleading you into these behaviors. Okay, so that's why the DSM, when it discusses these diagnoses, it doesn't say, oh, the best way to treat this is by giving them this pill, or the best way to treat this is by engaging them in this therapy. It leaves that open-ended because it's not a one-size-fits-all. In terms of therapeutic approaches, you have the cognitive and the psychoanalytic approach. The cognitive behavioral therapy is the most popular for these types of disorders. Okay, cognitive behavioral therapy, or CBT, was created by Albert Ellis. Okay, he came up with rational emotive therapy. Albert Ellis had a phobia of his own. He was afraid of talking to women. He had anxiety about talking to women. So how did he get himself over that fear? He forced himself to talk to over 100 women. He desensitized himself to that anxiety, thus allowing that phobia to fade away. And so he created his rational emotive therapy to follow that type of flooding experiment. Okay, so with that, he uses the ABCs: action, belief, and consequences. With A, action, the activating event happens. Then B, you have a belief held about an event. Then C, consequence, you have an emotional reaction to your belief. So for instance, if someone has a phobia of feathers, okay, the activating event happens, you see a feather, that's A. B, your belief, that feather is dangerous, it's coated in diseases, and I'm going to die if I'm anywhere near that feather. Then as a consequence of that belief, you have an emotional reaction of fear. You start panicking about the feather. Okay, so he says we need to change the B part. We need to change the belief. And so in order to do that, he created exposure therapy, and he added it to response. Trying to spell response prevention. So exposure to the thing that causes your fear, and then a prevention of the maladaptive response. This is also known as flooding. Okay, so exposure therapy to what you're afraid of. Now, this doesn't mean someone who's afraid of feathers is going to be thrown into a pit of feathers and left to have a heart attack. Okay, you do it in steps. You build a anxiety hierarchy. Okay, so if someone's afraid of feathers, the first step would be talking to them in the room about feathers. Then you wait until they calm down. So they're experiencing the fear just from talking about it. And then they go back to homeostasis. Then the next step is across the room, as far away as possible from them, you take a feather out of an envelope. They're gonna freak out, okay? But eventually their body goes back to homeostasis. So the next step is to go up that anxiety hierarchy, move a little closer to them with the feather. That may take another 30 minutes of hyperventilating and panic until they reach homeostasis again, until eventually you get to them holding the feather. And then they're going to rewire their neurons to no longer be afraid. They've changed the belief about feathers. You used to believe being around feathers would kill you. Now that you've been exposed to your fear, you found out that your belief was inaccurate. And so now you're changing it cognitively so that you no longer have the same consequence. You no longer have the same emotional reaction. Okay, this is one of the most popular therapies in treating phobias and anxieties. The psychoanalytic therapy, which dates back to Sigmund Freud, involves talk therapy. It involves free association. So you talk about your fears, and then eventually you'll come across something in your unconscious that ties into why you're afraid of feathers, like a repressed memory or a repressed emotion. Okay, so this deals more with free association and figuring out what your unconscious has been afraid of so that you can rationalize it and then be free of that phobia. The biomedical approach is using medications or drugs to treat anxiety. So anti-anxiety drugs, Xanax, Ativan, Valium, Vistaril, okay, any of those depressants that would depress your sympathetic nervous system. Because remember, your sympathetic nervous system is the one that's flooding you with cortisol and other stress hormones. So it delays that sympathetic nervous system and keeps you in the parasympathetic nervous system to operate. You can combine these therapies together, the biomedical and the clinical, or you can just do one or the other instead of both. It's not one size fits all. Are we good so far on anxiety disorders? All right, so we have covered anxiety, OCD, trauma and stress related disorders like PTSD. Now we're going to move on to motor disorders like Tourettes Syndrome, somatoform disorders. This is where a person believes they're ill. Okay, so somatoform isn't faking it. Okay, it may be hypochondria, but it's not faking it. They literally believe that they have an illness and that it's serious. Factitious disorder is when they know they don't have a disease, but they pretend to get attention or sympathy, or they intentionally make themselves sick. This is where we're going to talk about Munchausen's and Munchausen's by proxy, okay, with the factitious disorders. Okay, so first off, motor disorder. Y'all have probably heard of Tourette's before, but again, popular media often misportrays Tourette's as a single symptom. They'll typically display Tourette's as somebody randomly yelling out cuss words at inappropriate times. Verbal tics and involuntary verbalizations is a symptom of Tourette's, but there's a wide spectrum of symptoms, and it's not always going to be cuss words that they yell out. It could be literally any word. Okay, in one case study I saw, there was a woman who every couple of seconds she had to say the word biscuit. So she'd be talking to biscuit you, and then in the middle of her biscuit sentence, okay, she would just be saying it and she would twitch along with it. It's because you have this obsessive thought about the word, and it's building up a pressure valve in you, and you have to say the word in order to release that pressure. Okay, so it's almost impossible for them to retain the word. Now, if you're saying something adorable like biscuit, okay, not that big a deal. But if you're going around dropping the B word and the F word, and all sorts of different words that you can't say, then that's going to be problematic, especially if people don't understand that you have Tourette's syndrome. In addition to involuntary verbalizations, you also have involuntary muscle movements, hence why this is a motor disorder. Okay, facial tics are common in Tourette's syndrome. Punching the legs or moving the arms or beating the chest. Okay, all of that can be muscle tics that are a result of Tourette's syndrome. Now, biologically, why does this occur? Well, scientists believe that it's because of an imbalance in dopamine and norepinephrine. Dopamine is the pleasure chemical of the brain, but it also helps to control movement. Norepinephrine is like adrenaline, and so that can also impede the body's response to stress and movement. Okay, so they hypothesize that those imbalances could be related to this particular motor disorder. Does this make sense so far? All right, so now we're going to move on to somatic disorders. And y'all have probably heard of hypochondria. The new term for that, hypochondria, is the old term, but the scientific term for that today is somatic syndrome disorder. This is when a person manifests a physical ailment, but there is no physical cause. Instead, there's a psychological cause for their physical ailment. And usually that's going to be tied back to stress or trauma. Like y'all may have seen the Sherlock Holmes, the BBC version with Benedict Cumberbatch. When John Watson came back from the war, he walked with a limp. It wasn't because he got shot in his leg. Okay, it was because of the stress and the depression that he was under. Okay, so psychological problems manifesting as a physical problem. Now, technically, there's two types of somatoform disorders. And the first one is called a conversion disorder. Okay, this is when you can have extreme, severe physical problems that have no physical cause. They're from stress or anxiety or a psychological source. So a person with conversion disorder could develop paralysis, numbness, or even blindness. And there's no medical reason for that occurring. Can you imagine just like you're stressed one day and then you go blind? Like, you'd be like, what's happening? Okay, so lots of anxiety, okay, very, very difficult. And so they report physical problems that are literally there. They're not making them up. It is there, but there's no physical cause. Okay, it's in the psychological cause. The other type of somatoform disorder is hypochondria. This is where a person has a high fear or anxiety about developing a serious illness, or that they're convinced that they have it already. So like if they have a headache and then they go on WebMD, y'all know what WebMD is going to tell you. WebMD is going to tell you you're going to die in 7 days. It's going to be like, you have a tumor, okay? Or like I'll go on WebMD and be like, I have a stomach ache. And they're like, yeah, it sounds like you have prostate cancer. And I'm like, I'm pretty sure I don't. Like I'd be willing to bet money that I don't. But okay, WebMD. Okay, so they'll take every little minor physical symptom and believe that it's more serious than it actually is. This doesn't mean they're faking it, okay? They believe that they're ill. They actually believe that they're ill, okay? It's just that it's blown out of proportion, okay? It's a fixation on minor symptoms that builds up anxiety in them until they believe this is it, I'm going to die, okay? Another part of somatic disorders is illness anxiety disorder. This is not necessarily meaning that you have the illness or you believe that you have the illness, but rather you're obsessed with getting it. Okay, so you're trying to avoid getting the disease. Now, there are two types of people with illness anxiety disorder. There's the care-seeking type, which is constantly going to the doctor and saying, hey, I've had this symptom, I need you to test for this, I need you to check for that. Or care avoidant type, where they believe that they could be sick, but they refuse to seek medical help. Okay, so this can manifest in different ways. So what causes these somatic symptoms? Well, if we look at the psychoanalytic approach, the Freudian approach, of course, this ties to your unconscious. You have repressed emotions that you are not looking into. Now, these are unconscious. This is different from suppression. Suppression is when you push it away on purpose. Repression is when you push it away without even knowing it. So you need to get those repressed emotions out, or else they're going to manifest as physical symptoms, physical illnesses. Okay, that's kind of how it worked out with John Watson in the Sherlock Holmes series on BBC. He went to a therapist and he was having fun with Sherlock Holmes, and then eventually he was able to walk without a limp. The behavioral approach says that people with somatic symptom disorders get rewarded for their attention-seeking behavior. They get attention from doctors or nurses or family or peers, or they get medication that encourages their behavior of going to the doctor over and over again. Okay, although they must have good health insurance, because I try to avoid the doctor at all times. I once took an Uber to the ER. I wasn't paying for an ambulance. Are you kidding me? On a teacher's salary in this economy? Guess I'll die. The sociocognitive perspective is when people pay too much attention to their health, and so they're more likely to realize that something's going on. Okay, but not so much that it's actually a serious thing. Okay, if you go into a CT scan, the doctors are going to find something. Okay, there's always going to be something wrong going on, not necessarily causing problems. Maybe you have a kidney stone or something, just something going on that would show up on a CT scan. Okay, but if these patients are so in tune to their health that they notice even the tiniest changes, like a slightest change in a mole on their shoulder or a blemish, or they feel an ache in their thigh, they're immediately going to assume the worst. They're immediately going to assume something is wrong. And this can lead to confirmation bias. Let's say that that person notices a spot on their elbow or whatever, and they go to WebMD and they Google spot on elbow. Well, they may ignore normal things like ingrown hair or scab or a burn or something, and they may go directly to melanoma. And they're gonna be like, I knew it. I knew I had cancer. This spot proves it. The internet proves it. This is confirmation bias. They ignore all other information accept the information that confirms what they already believe, which is that they are sick. Are we good so far? Now, factitious disorders are different from somatic disorders. Factitious disorders is when people deliberately try to get sick or try to make it look like they're sick in order to get attention or sympathy. Okay, there are two types of Munchausen's syndrome. The first Munchausen syndrome is when one fakes psychological or physical illnesses to get sympathy for themselves. In one case study I read about, doctors were bamboozled by this woman who was going through septic shock and blood poisoning. They're just like, we don't understand how you're sick, but she was deathly ill. And then they found out that she had been taking fecal matter and injecting it into her own IV to make herself sick so she could stay in the hospital. Okay, that's Munchausen's. Munchausen's by proxy is when you inflict harm or symptoms on somebody else in order to get attention, usually somebody who's in your care, like a child or an elderly person. Okay, Eminem, his mother suffered from Munchausen syndrome by proxy. She would take Eminem to hospitals, to doctors all the time, trying to make him sick so that she could get attention from the doctors for her son. Okay, there's another girl. There's this documentary show. I forget what it's called, but it was like a little girl with cancer. Her head was shaved, but it turns out her mom was making her sick the whole time and pretending that she had cancer. That's Munchausen syndrome by proxy. I do have a video of this in the lecture series that I'd really like y'all to watch, because it shows the harm that parents can cause if they suffer from this syndrome and they impart that damage upon their children in order to get that attention. It can be deadly. Okay,